just need to know about SARS-CoV-2, and we'll just talk about the virus first in terms of survival and how can you kill it, and then how does it spread and where do you find it in patients. This pictorial just gives you a sense of the size. It is quite large for viruses, but certainly smaller than bacteria and red cells. So this table shows you the comparison between SARS-CoV-2 as with influenza, SARS, and MERS, all of which are similar in that they're respiratory viruses. So SARS-CoV-2 is larger than SARS was, so it's 125 nanometers versus 80 to 90. The RO is very similar actually, and RO is something that changes, so with social distancing it will definitely fall. The case fatality rate, as you can see, is quite low compared to SARS and MERS, but higher than influenza. And the case fatality rate really is reflective of how many people are being tested in your community. So the more you test, the lower it gets, just because you'll get the more mild cases. And definitely SARS is a pandemic, as we all know, similar to what H1N1 in 1917 was. So in terms of survivability, this paper was published in the New England Journal. It was an experimental study looking at SARS-CoV-1 versus SARS-CoV-2 and how are they different, because clearly their infectiousness and the time of infection range is different. So what they found under different environmental conditions is that SARS-CoV-2 is fairly stable on plastic and stainless steel up to 72 hours. And we know this about viruses. They tend to survive easily on flat, hard surfaces, and they don't survive well on soft and rough or uneven surfaces. So for copper, it was 4 hours, and for cardboard, it was up to 24 hours, so quite a bit shorter. Even though it survived 72 hours, the viral load did drop over those 3 days significantly. And when they generated aerosols in the lab, they found that the half-life was about just 1 hour. So not super long. So overall, the SARS-CoV-2...
I make you host, so you need to accept the people.
Overall, SARS-CoV-2 was very similar to SARS-CoV-1 in terms of its survivability on surfaces. So the fact that it's more infectious early on is more related to host factors, not so much the virus itself. The hospital-grade cleaning products all work very well, and here's a table that shows you that. We use alcohol on our hands, and it's because chlorhexidine is not effective. So we always want to use alcohol, or good old soap and regular detergent works very well, and is actually preferred. So quaternary ammonium compounds also work well. So pretty much all the hospital-grade products are very effective at killing it, and you can see from the exposure times it happens very quickly. 30 to 60 seconds. We always recommend at least a 1-minute contact time. SARS, as you know, SARS-CoV-2 or COVID-19 is spread mainly by droplet, but there is some aerosol generating procedures where you see the aerosol transmission. And the difference is really the size of the particles that are coming out of your mouth. And so droplets are larger, they just drop to the floor. They do contaminate the environment, and that's where we see what we call fomite spread. So things get contaminated. It's very common with bacteria as well, and that's why cleaning in hospitals is so important. One thing to point out is that similar to SARS and MERS, actually, there's more super spreader events. So generally one patient won't spread it to too many, if at all, but then there's times where there's a patient who's infected or a person who's infected who spreads it to many people, and you'll hear about those events. And we don't understand them well, but they tend to be the ones that are driving the epidemic. So, sorry, in terms of masks, I think everyone knows if it's droplet, surgical masks are quite protective, but for aerosol, you need the higher grade N95 masks. So here's a list of the aerosol generating procedures. These are the times that you really do want to be wearing an N95 or a PAPR. So they're broken up into anesthetic versus surgical. I think for surgical, the other concern is when you're doing laparoscopic surgery and also any kind of aerosol generating procedures. But the way to think about that is, where is the virus in the patient's body, and is it in the fluids that you're going to be encountering? So here's a paper from China where they looked at about 205 patients, and they collected over 1,000 specimens at the time they were ill with SARS-CoV, with COVID-19. And it's a respiratory virus, so the main place it's found is in the respiratory tract. BAL and sputum have the highest rates of finding the virus. After that, besides respiratory tract, we see it in the feces. We haven't really proven fecal-oral transmission, but it's certainly something to think about. Blood, though, most patients are not viremic. The numbers are between usually 1 and 5%, at the most 15%, but in this paper it was just 1%. And here's the diagram from the paper, and I circled the brown triangles because that's the feces. So they did find detectable levels of virus, and when they looked at 2 stool samples, they could find live virus. So we do worry more about stool being contaminated with the virus than blood, for sure. In terms of nosocomial transmission, and this is something we worry about in our hospitals, is if patients are together in a cubicle, what is their risk of getting it from another patient? Of course, our goal always is to separate patients and not put them in an open cubicle. But to look at that, there hasn't been any studies that have looked at it, but we can look at secondary attack rates in families. And CDC and a study in Japan, both looking at it, found about 10 to 15% secondary attack rate. So and we see family clusters, and again, most of the time, all of the family members don't get it. So the secondary attack rate is about 15%. In terms of healthcare workers getting it, Hong Kong had a study where 2.7% of healthcare workers had unprotected exposure, and none of them were infected. And then I'll show you one from Singapore in which also the same was true. What about environmental contamination in terms of a patient's room? So NCID here in Singapore did look at that. They had 2 patients, one of which had a fairly high viral load, and they looked at samples in the environment before and after cleaning. They found a lot of virus where you'd expect it, around the patient bed and things, but also in the toilet and the bathroom areas, which speaks again to seeing it in the stool. But when they did the cleaning and did repeat swabs, they didn't pick up any virus. So the cleaning was very effective. In this study, they also swabbed some gowns and some shoes, and the front of the shoes, one out of the 2 had virus, but it didn't track out to the anteroom or the corridor at all. So this is a paper that was published, a letter from Changi. It was an inadvertent exposure of a patient who was intubated. It was a difficult intubation, and they didn't find out he had COVID till after extubation. When they looked at the 41 healthcare workers who were exposed, most of them were wearing a surgical mask because that had been our policy, and only some were wearing N95s. And when they followed them, both at the time they sent them home for the 14-day quarantine and at the end of the 14-day quarantine, none of the workers swabbed positive and none of them fell ill. So again, it speaks well to the fact that good hand hygiene and even surgical mask works, but of course we do recommend N95s for intubations. This is a letter to the New England Journal that hasn't been published, but I just found it. It's preprint, and actually it's been accepted, it just hasn't been published. But basically in China, of their 77,000 cases, 4.4% were healthcare workers who got it on the job, and 23 of them died. You can see the average age with the range of 29 to 72, and many of them were actually rehired physicians, older physicians. There were 8 surgeons and 3 were ophthalmologists. Interesting, none were infectious disease doctors and none worked in an ID hospital. And again, I think this speaks to when patients are segregated at the time of entry, so in triage to the right rooms, and when people are wearing their PPE, it is quite effective, and the PPE does work. So on to talking about the clinical spectrum of COVID. The things to think about are what is the average incubation time. So if someone got exposed, usually when do they get sick? What is the time that they need to be intubated if they do? And then what are the risk factors for morbidity and mortality? And then who should you think about it in? I think everyone knows the numbers overall, and these have held true from every country so far, that 85% of patients do fine and really don't get very sick. 15% do go on to require some kind of oxygen or other support. And then 5% become critically ill, where they really have multi-organ failure and require intensive ICU care, of course, and often those are the groups that have a mortality. So the average incubation period is about 4 to 5 days. It can be up to 14 days, but usually it's just within 4 to 5 days. It can be as early as 1 day, but usually it's 3 to 5 days. The average time for really getting sick is day 9. That's the tricky part. Patients can look well and feel well for the first 6 days, and then they come in and get tested and they say, but I'm fine, and 2 days later they crash. So that's the time to worry. Morbidity and mortality is definitely older age. It's much, much higher in people who are older, 65 and above. And cardiac disease is a risk factor. Obesity is becoming a huge risk factor, and diabetes. So who should you suspect? We always say, you know, just like anything else, it's a infectious disease. So ask about contact with a known case, recent travel, family members being sick. It's always good to ask, or close contacts. And then are there any clusters, and have they been around those clusters? So just to give you a sense, COVID can be really very severe or very mild when it presents. This was a patient who had presented 2 days earlier and actually just had a mild fever, but a normal exam. He came back 2 days later, and at this point reported that his wife was also having a fever. So there's a family member who's sick. And at this time, he had a temperature of 37.8 and crackles on exam. And when labs were done, they were quite significant. He had elevated CRP, liver enzymes were a little bit elevated, and LDH was high. So he did not have any known contacts other than his wife was sick, but he ended up progressing fairly quickly and ending up in the ICU. This was his x-ray at the ER, the second visit, and you can see he had an infiltrate here and here. It's quite subtle, which is often how these x-rays are. Now this patient is a 23-year-old who was very well. She came in because she had a cough for 1 day, but also she came in because her employer had just been confirmed. So because she had a cough, she decided to come in. Her labs were completely normal and her chest x-ray was normal, but she did swab positive. This is another patient who was admitted and tested positive, and you can see her x-ray. You can see these sort of splotchy infiltrates even bilaterally, and she progressed very rapidly, which often happens. So she came in around day 7 of illness and then progressed pretty fast. So the symptoms of COVID are quite unusual in that they can be almost nothing to just, you know, loss of smell and loss of taste. You would have heard about that being quite a common newly recognized phenomenon that does happen with other viruses, but for COVID it seems to be more prominent. Patients can just have a dry or itchy throat or a sore throat, dry cough, blocked nose, runny nose, very mild URTI symptoms. Also, though, there can be systemic symptoms just like influenza with fatigue, myalgias, headaches. Sometimes patients have red eyes. Diarrhea happens not infrequently. Sometimes it's just twice a day. Other times it's the main manifestation, as well as nausea and sometimes confusion. So in terms of the signs to look for, patients often have crackles. So even before the chest x-ray shows much, on exam you will hear crackles, either unilateral or bilateral, and you should definitely listen for that. Red eyes is not uncommon, higher respiratory rate. They can desat with movement or get short of breath with just walking to the bathroom. Much less common could be a presentation of confusion. The spectrum, again, like I said, is broad from ERDs to pneumonias to AKI. We're seeing more and more myocarditis and MI, and you would see that reported in the literature. And patients do have this very hyperinflammatory picture when they become sick. So this is a postulated mechanism where early on, it's mainly viral, with a higher viral load, more fevers, and then as later, and this is usually about day 9, as I said, that's when the host inflammatory response can kick in. But not everyone gets this. The majority, again, 80% will just, you know, clear the virus and never mount a bad immune response. So as a surgeon, you're going to be evaluating your patients, and again, the things to look for or ask about are dry cough, fever, protracted fever where you go to a GP multiple times has been shown to be a risk factor, shortness of breath, but it could be very subtle like loss of taste or loss of smell, and that may be your easiest question to ask, as well as exposures. In terms of physical exam, again, look for the fever. It can be mild, 37.5 and above, but it can also just be sort of sustained at 38. Listen for crackles and wheezing, but mainly crackles. And then look at the labs. Look for lymphopenia, leukopenia, which is not uncommon, but that along with a raised CRP in the right setting can make you worry about it. The infiltrates are often peripheral. And as you may have heard in China, especially before there was good testing, CT scan showed the early changes even before a chest x-ray, and it's often very peripheral looking signs. So one of the things that people want to know about is the swab and how good is the swab. So early on, the sensitivity of a swab, if you do it well, which is a good nasopharyngeal swab, maybe also sweeping the anterior or the mid-nasal cavity, is highly sensitive. But we generally recommend doing 2 over 24 hours to really rule it out if you catch people in that early stage. What I want to point out is by the time patients have pneumonia, the sensitivity of the swab really drops to 72%, because at that point, the virus is in the lower respiratory tract. So if you can get sputum or ET fluid, that's much better, but you may not be able to diagnose the pneumonia with just a swab. This is the MOH criteria to show what PPE is considered protective. And the only things I want to point out is for aerosol generating procedures, definitely wearing an N95 with gown, gloves, and eye protection is necessary. And for casual contact, so if you were exposed to a patient for less than 30 minutes, face-to-face, but casual contact, and you were wearing your surgical mask and did hand hygiene, then you're safe. There's no follow-up required. And that's worked for us. We've actually stratified our exposures or breaches that way. And so far, our breaches have not had infection. So in conclusion, COVID-19 has many manifestations. It's kind of weird. It makes sense, right? It's a coronavirus, and coronaviruses cause the common cold. So you see that spectrum, but SARS was also a coronavirus, and there's an 80% similarity between the two virus DNA. So you see the SARS spectrum as well. So it's a huge spectrum. And when people go on to get the SARS, it's usually after day 9 or around day 7 to day 9. So when you talk to your patients, take a very targeted history, look for the signs and symptoms we talked about, look at the labs, especially the lymphopenia, CRP, with a normal procal, and remember your PPE, and that it's mainly spread by droplets and fomites, and that normal hand washing, 70% alcohol, and then the normal hospital grade cleaners will disinfect it. And then the swab technique matters. Thank you. That's my last slide.
Thank you very much for that great talk. Are there any questions? We'll take 2 questions from the audience. For Jyoti, please, if you could identify yourself. Any questions from the floor? I think there's in the chat room.
Hi, Jyoti. It is Brian here.
Hi, Brian.
Hi. I was just wondering, is there any concern about blood transfusions? As in, because in the slide you showed about Chinese patients, there were some that had a temporary, short-lived viremia.
Sure.
So should we, is the blood bank screening for COVID?
Most unmuted all, but
I know right now they're not.
look at the mix.
I don't actually know if they are yet. I think we have a lot of unknowns, and those numbers so far, we don't even know the stage of those patients who were positive. We know that in China, those early studies, as you can imagine, very
Thanks, Jyoti.
yes.